Can you hear me? Yeah. Pediatric bone marrow transplanter, or cord blood transplanter, maybe the better appropriate term, from Duke University. And we're very pleased to have you here today. Thanks.
Well, thank you, Ali. I'm delighted to be here. I want to thank Florian and everybody at ALD Connect for the invitation. I hope I can do justice in the next 30 minutes and tell you a lot about transplant, unrelated umbilical cord blood transplant, other types of transplant, our own experience. But I'll tell you not everything. I'll tell you enough so you invite me next year. And then I will have some left that I can talk about next year. I also want to recognize Elisa Seager. She's been such a big advocate for patients with ALD. I had the honor and privilege of taking care of her son, Aiden. So thank you for everything that you're doing. My slides are up there. I think I can handle this. Okay, so I'm at Duke University. I've been at Duke for the last 15 years. I used to be at Sloan Kettering for about 10 years before moving to Duke. Most of the experience that I have gained in treating children with inherited metabolic disorders, and as you know, ALD is one of those diseases, all of that has been gained at Duke University. When I was at Sloan Kettering, there wasn't that much of metabolic disease transplant happening. So there are certain centers around the country and around the world that have a lot more experience in dealing with these patients and these kinds of transplant. So I draw a lot from my experience at Duke University. I'll try to move closer to the slides, sometimes on this side, sometimes on that side. It's 4 days before election. I don't want to make any political statement about moving to the right or the left. So this is a cross-section of a brain from a patient who had transplant for Krabbe disease. Unfortunately, the patient passed away a number of months after transplant because of a number of different issues. And the point I'm trying to make on this slide is that this was a female patient. The donor was male. And we were able to, the family was very gracious and donated the brain for us to study. And we were able to see donor-derived female cells, not only in the cortex, but in many, many different parts of the brain. And also, in addition, that the pathological changes of globoid bodies, which are common in patients with Krabbe disease as they progress and cause damage and a reflection of injury to the brain, they did not occur in this brain, again showing the transplant. This work was done in collaboration with Evan Snyder and Wesley Georgina. And it, to us, although there were animal experiments before that, there have been cross-correction models in the lab on a test tube, but this was a very graphic reflection of what you can do with a successful transplant, where you're able to get donor-derived cells in the brain that is able to help the brain. I have added this slide. So after some of the conversations we had earlier in the day about different types of transplantation. So I'm hoping, Florian, and Ali, you'll give me 1 extra minute on this talk. So the umbrella terminology that we use is hematopoietic stem cell transplantation. How we do this transplant depends on where you get the donor cells from. And if you get the donor cells from the bone marrow, here we are taking it out from the back of the donor. It's a bone marrow transplant. If you take it out from peripheral blood after giving a granulocyte colony stimulating factor to the donor, it becomes a peripheral blood stem cell transplant. And if you use blood from umbilical cord blood or placenta, there's a placenta sitting here. After a baby is born, the afterbirth is brought into the collection room. There is blood in the placenta there, and you can see the cord that's collected, then it's processed, stored, and we have all the information on that cord blood unit. And if you use this cord blood unit, then it's umbilical cord blood transplantation. You're essentially giving high doses of chemotherapy to the patient to get rid of the patient's immune system, and then reconstituting the bone marrow or the hematopoietic system and the immune system with donor-derived cells. And some of these cells will convert and go to the brain and help the brain in patients with inherited metabolic disorders. There has been a number of studies that some conditioning is actually required to not only engraft in the bone marrow, but also to help the brain, where some of the cells will be derived from the cord blood unit. It's not only that we think that there is the microglial cells, there is also a little bit of data coming out which shows that maybe some of the cord blood cells may be converting into neuronal cells. So before I go further, I want to just set the scene where things were, say, 15 years ago. So this was a paper that our group published in 2008, so that's exactly 10 years ago. This was 159 patients with inherited metabolic disorders who were transplanted using unrelated umbilical cord blood. You would notice here that there were a number of patients who were less than 1 year of age, I think almost 50. So we have done these so far we have now, this is 10-year-old or 12-year-old data, we have done now more than 300 transplants for inherited metabolic disorders. And a large number of these patients are very young, and many of these have infantile Krabbe disease, early infantile Krabbe disease, and many other diagnoses that have a much faster trajectory of deterioration compared to cerebral ALD. But the point I'm trying to make here is that we can do transplant very early in life, and these numbers decrease. These are the common diagnoses that we have transplanted: ALD, Hurler syndrome, MLD, and Krabbe disease make up the majority of the patient. We learned a lot of things with this analysis 10 years ago, including what kind of cell dose we should use for transplantation. I will not go into the details of that other than to say that we have a good idea of how to select the cord blood unit for the best outcome after transplantation. So that certainly is one of my topic was improving cord blood transplantation. And one of the improvements that we have been able to bring about is to have better selection of cord blood unit on the basis of cell dose, as well as donor matching. And the technology for both has also evolved during this period. But this is the important slide that I would like to reflect on for a little bit. And this is the survival, overall survival, of that cohort of 159 patients who were then divided into high-performance group, which was a Lansky score of 80, 90, or 100, or low-performance group, which were a Lansky of 70 or lower. It's a surrogate marker for how advanced the disease is. If your disease is advanced, your Lansky score or performance status, it's even a more basic measure than the functional score, but it does measure the level of disease involvement. And those patients whose disease is more involved, they had worse outcome, not only in the first year after transplant, but also going up until at the time of that analysis, 10 to 11 years after transplant. And you can see the stark difference between these two groups. And what we have learned over the years, and that's another improvement, is that it's really important to select who would be the right candidate for transplant. Just because you can do a transplant doesn't mean you should do a transplant. And the sad fact is that there are more patients who come to us who we cannot do transplant on because the disease is too progressed. It's also important, there were some questions in the previous session about donor chimerism. With the myeloablative, for those in the transplant field, it's really important to understand what we are doing is a myeloablative conditioning. So we're using two chemotherapy, busulfan and Cytoxan and ATG, and then doing this transplant. With this conditioning regimen, we achieved more than 90% donor chimerism in almost 98% of the patients. And these are all durable donor chimerism. Even 10, 12, 15 years later, these chimerisms are holding up, which means that you continue to have these donor-derived cells all through the life that we have been able to follow and some of these patients, I think the first transplant we did using unrelated umbilical cord blood transplant was in 1995. So it's been 20 plus years that we have experience on. Just using that graph a little bit more in terms of numbers, the overall survival in those patients who were in the good performance status and who I think would be the transplant candidates now, the 1-year survival was 88%, and then 5-year survival was close to 80%. So what we also saw, and I don't have data on because of time, but I can summarize those findings into that those patients who were transplanted as neonates early in the course of the disease had a less rapidly progressive disease and had high performance status at transplant, had better outcome, not only in survival, but also in terms of neurological outcome. And a lot of this has been published by our group over a period of last 10 to 15 years. In Hurler syndrome, which is also one of the inherited metabolic disorders, after transplant, we have shown that the neurocognitive function actually can get back within the normal range. And this is the age of transplant. Those patients who were transplanted as early as a few months of age, their recovery of neurocognitive function back into the normal area is much faster and more complete than those who were transplanted later. So it's really important to do this transplant for a patient who needs a transplant as early as possible. This was a result of a collaborative study which was done between Duke, Minnesota, and Europe. And what we see here is outcomes of Hurler syndrome in 258 patients, out of which 116 were cord blood transplants, that you will notice that after a cord blood transplant, full donor chimerism was 92% as opposed to unrelated donor, T-cell depleted unrelated donor, and even identical sibling. The full donor chimerism is higher after cord blood transplant, and this was statistically significant. And the reason it's important to have full donor chimerism is because it's the donor-derived cells, the longevity of those donor-derived cells is that what you want to achieve after a transplantation, and we seem to achieve that better with unrelated cord blood compared to other donor sources in this study. And it's another way of looking at the same data, and those patients who did not have high levels of donor chimerism require more cord compression surgery, which means that they had more impact or negative impact of the disease compared to those patients who had full or high donor chimerism. So the advantages of unrelated cord blood transplant in this context is that we are able to use less stringent HLA matching, which means that more patients can find donors. Cord blood units are very rapidly available. They cause low graft versus host disease, one of the concerns after transplantation. All units are CMV, it's a virus, cytomegalovirus, are negative, and there is no risk to the donor. And this is data from New England Journal of Medicine, NMDP, which shows that if you use cord blood donors, even for African American and other ethnic minorities, there is more than 95% chance of finding a suitable donor. So essentially, we are able to find a suitable donor for almost every patient that we need a transplant for. There are clearly areas of improvement that are needed in the transplant. We need to improve the mortality, infection, veno-occlusive disease, and other complications. We need to improve engraftment and hospitalization duration. And then another really important issue in terms of these transplants for inherited metabolic disorders is that we need to get the cells to the brain as fast as we can so they can do the good work that they are supposed to do. I will not talk about this. I think ALD Connect is already doing all of this, and I laud the efforts of everyone involved in these. So there has been significant improvement in what we can do for infections in the post-transplant period. This is our own data, which shows that the infection or death related to Aspergillus infection has gone down dramatically over the last 20 years. And I think we can almost attribute most of this improvement to one drug, which is use of voriconazole for prevention of fungal infection in the post-transplant period. There are also newer agents that are available. One was just approved for treatment or for prevention of cytomegalovirus, which could be a problem post-transplant. There are other drugs that are available in clinical trial to take care of other infections post-transplant. And in children, adenovirus infection can be serious and life-threatening, and there is a drug which is in study right now, has not been FDA approved. This is one of the patients with inherited metabolic disorders who was treated with this drug, brincidofovir, in clinical trial. And you can see that the patient had failed initial treatment, standard treatment, and then had a rapid improvement in the adenovirus infection. And that child is still alive many years later and had been cured of adenovirus infection. Engraftment is the process by which the donor-derived cells take hold in the patient. That can take a number of days. Dr. Lund was speaking about if you engraft in 16 days or faster, then your outcomes are better. In our hands, on an average, after a cord blood transplant, it's in about 19 days post-transplant. That data is, to some extent, you cannot extrapolate data from one center to another. So it's really important. On the other hand, 19 days, it can be too long in some situations, and we are doing a number of things. We, as in collectively, the transplant community, some of these studies are happening at Duke, some are happening at Minnesota and Boston Children's and many other centers. And there are a number of, this is our data, and I already said that it's an average of 19 days of engraftment. There are a number of studies of cord blood expansion, improving the homing of these cells that will improve engraftment. I just want to point out one at the bottom, which is this study, not being done in ALD or in metabolic disorders, but in other diseases. And we are able to engraft at 6 to 8 days post-transplant after a cord blood transplant. So there are clearly ways by which engraftment can be made even faster. And then there is the idea that the faster you do the transplant, the better the outcome. So I digress for a moment to another diagnosis and dive a little bit deeper into one of the most serious inherited metabolic disorders, which is early infantile Krabbe disease. Most of these children will not survive beyond 1 or 2 years of age. We have done a number of transplants for early infantile Krabbe disease, and Hunter's Hope, so Anna, there you are. Hunter's Hope has been instrumental in pushing for advocating for Krabbe disease, and we have had a chance to take care of a lot of these children. So if you do transplant for early infantile disease, we have been able to do that in less than 2 months of age. And the data I'm going to show you to us was very revealing that if you do, there is a difference between if you do the transplant in the first 30 days of age, not days from diagnosis, first 30 days after birth versus 30 to 60 days after birth, there is actually a difference in the neurological outcome. So there were 16 patients, out of which 10 were transplanted at less than 30 days of age, 6 more than 30 days of age, and I would point here is that those patients who were transplanted early, only 1, so 10%, is in wheelchair. Neurocognitively, both of these groups are doing well. But in terms of motor recovery, those who were transplanted early have a much better ability to walk and motor recovery compared to those who were transplanted in the second month of life. So, and it's similar for expressive communication. Those who were transplanted very early have 80% of them have normal verbal ability compared to only 17%. These are small numbers, but this is an exceedingly rare disease. But it does teach us, or we learn from it, that we need to do transplants early, and even more important is to get the cells to the brain as early as possible. Even after a successful transplant, it takes a number of months for the cells to go to the brain because of the normal process of development of those cells. So to that end, that would be the last part of my talk, is what we are doing at Duke, and we call it the DUOC cell. DUOC stands for Duke University Oligodendrocyte-like cells, and this is the first FDA-approved trial, and so it's the DUOC 01 trial. This is really work that has been done in our lab for last 10 plus years, and that is to develop, so take the cord blood cells, the umbilical cord blood unit, and in a medium which favors growth of neural cells and neuronal cells and oligodendrocyte cells and other neurological cells, we are able to, it's not my work, I'm presenting it on behalf of our larger group, we are able to then coax some of these cells to take a different phenotype. And these cells are the DUOC cells that we have been able to then take it to clinical trial. So all of this is published, and you're more than welcome to go and read up on the development process of this. But for the sake of interest of time, I will go into just the basic elements. A lot of work has gone on to identify that these DUOC cells actually are derived from the CD14 fraction of the cord blood unit. Interestingly, we tried to do it with the CD14 cells derived from a bone marrow, but they were not successful in developing DUOC cells from the blood, or bone marrow, I'm sorry, as opposed to cord blood. It only is able to be derived from cord blood unit. We've done a number of animal studies and also lab studies to look at its effectiveness. And this is a model, it's called a cuprizone model, where mice are given cuprizone that causes demyelination, and then we have been able to inject mice with these DUOC cells to see if these cells will bring about any difference or not. So on this, you would notice that this is a normal brain with a lot of myelination, and if you get cuprizone, there is a level of demyelination. If these mice's brain is injected in the cistern with Ringer, the demyelination doesn't get better, but if they were given DUOC cells, there was an improvement in myelination, or there is remyelination. And this was also seen in electron microscope that you can see here, having thick, round onion peel layers around this is good. That's myelin. So there is more myelination or remyelination in those mice that were given DUOC cells compared to those who were not given DUOC cells. So we have been able to now take it to clinical trials. So the patient gets standard umbilical cord blood transplant using busulfan, Cytoxan, and ATG conditioning. Then 28 to 42 days, it was 28 days before, but we have modified the protocol to allow for manufacturing flexibility. 28 to 42 days after a successful transplant, we are able to inject these cells into the spinal fluid in the hope that then we are able to get these cells to the brain faster. I'm not showing the data, but we have looked at the enzyme activity, their functional ability, and all of those are existent in these DUOC cells. So what we do is, this is a cord blood unit. I don't know if the pointer is showing or not, but the cord blood unit is on the top left or your right. There are two bags within that bag, the large one, which is used for transplant, and the smaller one, which contains 20% of the cells, that is the used for DUOC development, which is developed in our own Duke's GMP facility and then is injected. So far, this is the eligibility criteria. So far, we have enrolled 27 patients. 23 patients have been treated. These are the dose of DUOC cells. There are a number of other patients in the pipeline. We have not seen any safety issues when the cells were derived from the same cord blood unit. We plan to treat a number of patients, and I think it holds great promise not only for inherited metabolic disorders, but other diseases, including ALS, AMN, multiple sclerosis, and other diseases. But we have to go through a number of other steps before we get there. So in conclusion, cord blood transplant has a proven and a particularly important role in treatment of children with inherited metabolic disorders. The outcomes of umbilical cord blood transplant continue to improve due to advances in donor selection, graft manipulation, and supportive care, and early delivery of cell therapy using DUOC cell in the brain in patients undergoing cord blood transplant may be useful, and it's being investigated. Thank you very much for your attention.
Thank you. And I'm sure there are some questions. I have a quick one. There is, I don't know how many cord blood banks are out there, but my understanding is each of them collects the cord blood and processes it in a different way. How does that, do you think, potentially affect all these interventions? So
that's a very important question. Thank you, Ali. Yes, there are many, many cord blood banks around the world, which is not a bad thing. But the quality differs. However, there is a system by which the quality is controlled and maintained and improved, and that is through FACT, which is the, somebody help me, FACT stands for Accreditation of Cell Therapy, Federation for Accreditation of Cell Therapy, and also the FDA licensing of the cord blood unit, and Duke's cord blood bank is both FACT and FDA accredited, and there are many other cord blood banks with the same level of accreditation. So when you're selecting cord blood units, you have to be very mindful of where you're selecting the units from. Does that answer? Yeah.
Salma? Wow. Sorry. As far as cord blood, do you think the day will ever come where they can manipulate a patient's cord blood so that if it had a mutation, that it wouldn't have a mutation? This way they wouldn't be fighting a foreign object within their body?
Yeah, I think that's very interesting. And we've certainly thought about it. And that will be a perfect combination of what I'm presenting and what Dr. Duncan just presented, which is you could do the gene therapy in the cord blood unit that was saved from the child and then be able to use that. Absolutely, I think that's possible. I don't know how to do it. I'm not technically savvy enough to do that. But theoretically speaking, I think that's very possible. That should be possible.
If you had to put a time frame from possibilities, what do you think that would be?
I will have a silent conversation with Bluebird.
Let's get it moving.
I think you're spot on. I think this is really important because of the issue that, say, you get market approval tomorrow. It would be nice if we can go beyond the trial centers and be able to deliver this therapeutic at every transplant center. And currently, the limitation is the transduction, right? So, any more questions?
So that was great, Vinod. So part of the mission and challenge for ALD Connect is to guide families and children from all over the country, and part of the questions we get is, you know, if I go to this transplant center, does it compare to what I get if I go to another transplant center? And whether we like it or not, I think we're sort of in the business of helping, you know, guide this process. And I know you've come up with, you know, guidelines around other diseases. Is there an opportunity here with several transplanters in the room to start thinking about are, while things might be different at different centers, is there some common ground one can agree upon? And maybe just to connect to some of the wonderful work you did in early Krabbe, in ALD, we actually would advise against transplants in the first years until there is a lesion in the brain, right? Yeah. And I think that's something worth re-emphasizing. Sure. And even if it's some parameters that you can all agree upon, and then list some differences, I think that would be very helpful. I don't know if you can speak to that.
Sure. Yeah. So thank you. 2 points. One is that there is obviously a need for the parents to have the ability to get a good understanding of what transplant is, how one does transplant at center A compared to center B, compared to center C. So having that kind of information available through ALD Connect and other groups like this would be very, very helpful. There is a lot of interest on in the transplant side. So I had briefly mentioned to you that from the transplanters group, the American Society of Blood and Marrow Transplant, there is some interest in that. So we are working in trying to come up with certain quote-unquote guidelines. Although what we do at Duke, because of our ability to do the Duoc cells, is different than what Minnesota or what Boston Children's is able to do. And I don't think there will be ever a time that everybody would be doing exactly the same thing, because that will impede science and development rather than advance it. Okay. Then the other issue that you had raised was more in relation to conversations about the timing, yes. So the timing is really important. While it is important to do transplant early, I don't want to give the wrong impression that everybody should be transplanted in first month of life. That was for early infantile Krabbe disease. The general consensus, and I 100% subscribe to it, is that for cerebral ALD, there is no need to do a transplant unless you have development of some findings. And whether it's just the MRI findings, or even if there is, say, abnormality in the brainstem auditory evoked responses, for example. So there is some value to looking into that a little bit further, although that hasn't been studied so much. Okay. Okay. Thank you.
I know, and I'm, as the mentee of Hugo Moser, I should shoot myself for what I'm going to say, but I think there's a consideration in this discussion that we should think about, is that it seems so far that the experience in adults with bone marrow transplantation is a lot worse than the pediatric. And if the pediatric transplantation is a long-lasting, lifelong-lasting effect, and you anticipate that, say, 50% of all men will develop cerebral disease anyway, would they be better off to have a pediatric transplant? If they get it. I mean, 50%, like I said. But I mean, I think this is something that, I mean, I guess we don't have the answer to it, but I don't know if we should categorically just shut it down, the idea. No, I'm talking about cerebral ALD in adults, right?
After transplant, the children did not develop AMN, and that data is still not published. I know that there's some, cohorts, but it hasn't been done systematically. I think if there's no AMN, or there's a suggestion AMN stops, then I think that changes the playing field.
Sure, right? Absolutely, and I agree with that. Okay. Okay.
Oh. I think something to consider as an aquapoise, or a place where we don't have information and data. One of the reasons we think the transplant is not helping AMN is because we don't really see correction of the spinal cord. There is no disruption of the barrier that allows the cells to come and home. This is all hypothetical. We don't have raw data, good data to say this is how it happens. But having said that, we do know in newborns that the blood-brain barrier is pretty wide open for a certain period of time. And we don't know that number either. So we don't know if it's a 1 week, or if it's 6 weeks, or if it's 3 days after you're being born. But the possibility, what I'm saying is we really don't know if a transplant could also, at that stage, correct defect, microglia, whatever it is in the spinal cord, because we don't know if we can get there. So not to put it completely outside, but this needs research. This probably needs a trial, or it needs something that it will take high risk, as many of the things that have been done in ALD, to answer, to transplant kids that have been born. But there is a possibility that what we don't see in children being transplanted is not happening, but it could be happening in newborns. Yeah, and also because the blood-brain barrier is more open when you're born. It closes down as you developed, everywhere in the central nervous system.
I agree with you, though. I think this is a topic that should be looked into, especially when the product of gene therapy is going to become available, because then we don't have the GVHD issue. But what do you think, Troy?
Well, I mean, so, I can't believe I'm saying it because Robert Good was my mentor and he did the first transplant in the world. Not everyone probably needs a transplant. And I think still giving a newborn busulfan, has inherent risks and changes their life. And that changes their lifetime risk of cancer and a lot of other things too. So, our recommendations are very clear. You must have T2 advancing lesions and gadolinium enhancement to be a transplant candidate. And that's what is required. There might be things to learn later on, but we'd have to have a much better understanding of chemotherapeutic metabolism by newborns. I see this seeing some of the adults in my clinic that have a brand new diagnosis of ALD and they're 30 years old. They've had a fantastic life. They have a new diagnosis, but they're really healthy. I couldn't imagine taking, a 10% risk and have to transplant them as babies when they had a great 30, 35 years before they got some diagnosis. That's a tough one to swallow. In the current paradigm, now as transplant evolves, maybe I'll change my opinion, but I think you need to have pretty rigid criteria to go to transplant.
I agree with that. The only thing I would say is that there is actually, we have done probably 50 plus transplants that are less than 2 months of age or 3 months of age. So we have a lot of experience doing it. I'm not advocating just because we have done it for certain other diseases that we do it for some other disease. It all depends on the natural history of that disease.
I don't mean to be misunderstood. I'm just saying, I think this is something we should really look into rather than categorically shut it down. That conversation needs to be emerged over the time as things get better. Thank you. Any more questions for this one? If not, then